Vice Chancellor Dr. Arzoo Yadav sir, Advisor to the Chairperson Sanjay sir, Principal Dr. Andy Soni sir, Hemant Malhotra sir, present eminent faculties, colleagues and the residents. Department of Radio Diagnosis is presenting today's seminar, CCR. I, Dr. S. C. Gupta, Professor Radiology, presenting a brief note on the departmental working before the start of CCR. Our department is situated in the lower ground floor of the old building, Central Radiology Department. And the course of our department started in 2009 with the 2 seats. At present, we have got 15 resident seats. And interventional radiology became a separate department in the year 2023 with 2 seats of TM at present. Total number of students have attained their post-graduation degree till date is 59. We have got 3 professors, 3 associate professors, 2 assistant professors and 3 SRs. Radiology department of Mahatma Gandhi Medical College is well equipped with the state-of-the-art equipments. We provide 24/7 radiology and imaging services. That includes routine X-ray, special investigation, digital and CR, radiography system, ultrasound, mammography, DEXA scan, computer CT scan. We have got 2 machines, 16 slice and 128 slices. We have got 2 MR, 1.5 Tesla and 3 Tesla. IIT is the close-up for me. These are the departmental statistics. In the last financial year, 2023 to 24, we did the total X-ray, more than 1,46,000, sonography, more than 66,000, CT scans, more than 17,000, and MRI, more than 15,000. So, on average, we do 450 X-rays per day. Sonography, including Doppler studies, are around 120 to 150 per day. CT scan 55 to 60 per day. MRI 45 to 50 per day on an average routine day. These are our equipments: routine X-ray, sonography, DR system, mammograms, DEXA scan, CT scan 16 slice, 128 slice, 1.5 MR Tesla, 3 Tesla MR. Till date, we have got 87 publications. Out of that, 46 were in the international journal and 41 was in the national journals. Besides our routine cases, involvement in the national and international clinical trials in our hospital that requires standardized reporting. We are involved in all the clinical trials. Active participation in the liver transplant and renal transplant imaging with intraoperative assistance and follow-up. Involved in the screening program in the camps like mammogram. Each year we celebrate World Radiology Day on 8th November. We celebrated first alumni meet of radiodiagnosis in October 2022. We do routinely the assessment of renal donor by the color Doppler and CT angiography, assessment of liver donor by the CT volumetry and MRCP. We are doing MR perfusion in stroke and the brain tumors, MRI diffusion tensor imaging for evaluation of the white matter tracts, volume rendered images of the various angiographies. We are doing routinely the mammograms. This is the normal breast on the left side and on the right side, so showing the tumor. It is a brief idea of our services offered and not possible to enumerate complete modalities in a few minutes. We are committed to render best possible services for the betterment of mankind. Now I invite Dr. Tushita Lakhera from the Division of Pediatrics, Cardiac Sciences for the case presentation. Thank you.
Thank you, sir. Good morning to all esteemed dignitaries, faculty members, and my dear colleagues. Today, we will be presenting a case of an 18-month-old child with acute respiratory distress in collaboration with the Department of Radio Diagnosis, Division of Pediatric Cardiac Sciences, and Department of Anatomy. So our case is an 18-month-old male child, second by birth order, born of non-consanguineous marriage, resident of Jaipur, brought by parents to the emergency room, informant being mother, with complaints of cough since 4 days, fast breathing and chest indrawing since 1 hour. There is a history of consumption of chana while playing 4 days back, following which he developed sudden onset, dry, paroxysmal cough associated with fast breathing and chest indrawing. With these complaints, he was rushed to a nearby clinic where he received symptomatic treatment in the form of oxygen-driven nebulization, resulting in transient relief of symptoms. Following the next 2 days, there was mild intermittent cough. However, on the 4th day of illness, the complaints worsened, the cough intensified, and there was increased respiratory distress, followed by bluish discoloration and a decrease in consciousness for 1 hour before arriving at the emergency room. There is a history of episodic noisy breathing noticed since the first month of life. There is no history of fever or running nose, no history of drug or food allergies, no history of repeated episodes of wheezing or nebulization in the past. There is no history of recent change in voice or any previous hospitalization. Birth history. The antenatal period was uneventful. No abnormalities were detected in the antenatal scans. The baby was born term by lower segment cesarean section, tried immediately after birth, and the birth weight was 2.9 kg. The immediate postnatal history was uneventful. There was no history of NICU stay and no feeding difficulties were reported by the mother. At present, the child is developmentally normal for age in all 4 domains. He is immunized as per age, as per National Immunization Schedule. The child is second of birth order, born of non-consanguineous marriage, and there is no history of bronchial asthma, atopy, or tuberculosis in the family. On presentation in the emergency room, the child was found to be unconscious and gasping. He was tachycardic with a pulse rate of 160 per minute, regular, normal volume, equal on both sides, no radioradial, radiofemoral delay, all peripheral pulses were well felt. Respiratory rate was 28 per minute. Blood pressure was 105 by 58 millimeters of mercury, measured in right arm supine position. This lies between 50th to 90th centile for age and gender. Child was febrile with a saturation of 64% on room air. He was visibly cyanosed. A biphasic stridor could be heard, and there was suprasternal, intercostal, and subcostal retractions. On detailed respiratory system examination, the chest movements were found to be decreased in the right mammary area, and a dull note was heard on percussion in right mammary and infraaxillary areas. Bilateral breath sounds were decreased, more on the right side than the left, and a wheeze was present on the right side. The Glasgow Coma Scale score was 5 by 15. Bilateral pupils were normal, reactive to light. Rest systemic examination was within normal limit. Investigations done on arrival revealed respiratory acidosis in the blood gases with a pH of 7.13 and a PCO2 of 67 millimeters of mercury. With this history, a chest X-ray requisition was sent. So summarizing our case, this is an 18-month-old male child with a history of noisy breathing noticed since the first month of life, presenting with complaints of cough and respiratory distress following the consumption of chana while playing 4 days back. On examination, there are decreased breath sounds more on the right side than the left with a wheeze. So with this history and clinical examination, I'd like to open the case to the audience for differential diagnosis. So any differentials from the audience? This is the summary of the case. There is a history of consumption of an organic foreign body.
Pediatricians, physicians, anybody just stand up and rattle off 2-3 causes at least? Okay, so because of the history of shortness of breath at birth, one possibility is congenital heart disease. What else? So they mentioned chanas 5 times, so there has to be some weightage to that, no? Who are the pediatricians there? Do you have any pediatric faculty? आप identify करो अपने third years को?
रेजिडेंट खड़े हो जाओ जो भी हो फॉरेन बॉडी एस्पिरेशन फॉरेन बॉडी एस्पिरेशन
And what happened after the foreign body? That body aspiration, that's it?
फॉरेन बॉडी विल बी इंफेक्टेड इन पर्टिकुलर
It will be lodged in a bronchus or a bronchial branch and produce collapse and produce infection. Right? Okay, very good. That is one scenario. Anything else?
So, given the history of witnessed choking with decreased breath sounds on one side and unilateral wheeze, first differential is that of a foreign body aspiration and its complications. Also, the history that follows the course of a partial obstruction turning into a complete obstruction 4 days later. So, any other differentials? So the next differential could be a reactive airway disease since there is decreased breath sounds bilaterally. But again, the unilateral wheeze is not something that we'd see in a reactive airway disease, and also there is no contributory family history, no history of bronchial asthma or atopy in the family, and no history of allergies per se in the patient as well. So there is one history that we've probably missed out on, and that's the noisy breathing since the first month of life. This was episodic, mild. It did not have any positional variation. It did not increase on crying or feeding. And it was mostly exacerbated during episodes of cough and cold. So this could be an underlying pathology like a congenital malformation, laryngeal, tracheal or vascular in origin, like a laryngeal web or laryngomalacia or a vascular ring. And then lower down in the differentials, a lower respiratory tract infection. However, there is no history of fever, and even the investigations do not reveal any markers of sepsis per se. So now I would like to invite Dr. Ashna, second. The presentation is for the respiratory distress is acute. The noisy breathing since birth could be, as I mentioned, congenital malformations. Congenital heart disease is unlikely. The child has no history of recurrent lower respiratory tract infections and has been growing well. There is no failure to thrive either. So unlikely to be a congenital heart disease.
Examination also revealed no murmur is there. X1 S2 normal, no murmur, no difference in the pulse volume.
The Chana story happened 4 days ago.
Yes, sir.
And the symptoms are only for last 1 day. So is Chana just a kind of false alarm? That is one. And because this happens very frequently with trauma also. A previous trauma brings attention to a pre-existing pathology, and the patient, the relatives, and sometimes we also try to attribute it to trauma. So we have to be careful. That is number one. And please go back to your... So why should a congenital malformation present now? If it is a laryngeal or tracheal malformation, there has to be some precipitating factor or event.
So we think that the acuteness of the episode is probably because of the foreign body aspiration, but this could be an underlying pathology which could have gotten exacerbated given this acute episode. would now like to invite upon Dr. Ashna, second year radiodiagnosis resident, to further the case.
This was a good example of how to present. The delivery of the presentation, the voice was audible, not very loud. There were pauses. Main points were emphasized by changing the tone and tenor of the voice. That is like highlighting or capitalizing or italicizing in written communication. In oral communication, that is how you highlight the important points.
Thank you, ma'am. Good morning to all respected dignitaries, faculty members, seniors and dear colleagues. Now that we are thorough with the clinical presentation, we'll move on to the relevant radiological findings. What you see on the left of your screen is a normal chest diagram, AP projection, and to the right of the screen is the X-ray of our patient. Question open to the house with the help of the clues given by the arrows. Can anyone point out the abnormalities that you can see on this X-ray, please?
Right lower lobe collapse.
Right, there's right lower lobe collapse. Anything else?
But दिख क्या रहा है तो बताओ, what are you seeing? What is that slanting down transverse line? What anatomical structure is that? जिसमें yellow or orange arrow लगी है, what anatomical structure is that? Anybody?
Oblique fissure.
Oblique fissure or transverse fissure? So why did you say collapse? Because the transverse fissure is being pulled down like this, and there is a opacity in the cardiophrenic angle, right? Okay. Go ahead.
So what we see is a chest diagram, AP view, showing an opacity as seen here extending from the right hilum to the right hemidiaphragm. What we also notice is that the lateral aspect of the right hemidiaphragm is very well delineated. However, as we go medially, this delineation is somewhat lost. The right cardiac border is well visualized. So, summarizing up these findings, this favors a right lower lobar collapse. Other than this, what we also see is the tracheal air column. We can also appreciate the left bronchial air column. However, the same on the right side cannot really be appreciated. Also, there is widening of the superior mediastinum, which at this age could also be physiological owing to the thymic shadow. So to summarize in brief what foreign body aspiration looks like on a chest X-ray from a radiology perspective, it is more commonly located in the right bronchus owing to its more vertical orientation. Also, skygrams are only able to detect 20% or lesser of these foreign bodies, and these show direct signs. The ones that are directly seen are actually radio-dense foreign bodies, maybe metallic foreign body. However, more commonly the foreign bodies that are lodged are organic in nature and are radiolucent. So we don't see the foreign body directly on the X-ray, but we do see some supportive indirect signs or some ancillary findings, which could be atelectasis, consolidation, air trapping, very commonly seen, segmental or lobar collapse. Now again, in our case, there was no evident radio-opaque foreign body, but we did see lobar collapse in our case as well. So to confirm with the help of the history, the foreign body, in our case, we did request for a CT scan. Now during a CT of the chest, images are taken in cross-sectional slices of the thorax and contrast is administered. The scan is taken in a helical direction in the caudocranial manner. And then the images post-processing are visualized systematically in the bony window, in the mediastinal window, lung window and soft tissue window. So for the protocol of the CCD chest, intravenous access is taken, contrast is administered. We use a non-ionic, water-soluble, iodinated contrast. The dosing is 1 to 1.5 ml per kg and the rate is almost 3 ml per second. Now moving on to the case. What we see here is an axial cut seen in the lung window for our case, and I'm starting from cranial to caudal direction. We are at the apices of the lung. As we go further down, we can see a patent trachea with ET tube seen in situ, endotracheal tube seen in situ. As we go further down, At the level of the carina, we can see this trachea bifurcating into the right and the left main bronchi. As we go further down, we notice the left lobar bronchus or the left main bronchus advancing further into the lung parenchyma. On further inferior scans, what we here appreciate now is there is a patent left bronchus, however, the same on the right side is not appreciated. What we also see is some soft tissue attenuation here in the window. To evaluate this soft tissue better, we switch over to the mediastinal window. And as we go further down, what we notice is some mucus impaction. Some mucus impaction here along the right bronchus intermedius and associated posterior soft tissue attenuation. Also, what we see in the mediastinal window as we go further up is the right brachiocephalic vein, the left brachiocephalic vein, the left common carotid artery, the left subclavian artery, the right common carotid artery and the right subclavian artery. As we go to a more inferior axial cut, what we now notice is these vessels forming a complete vascular ring which seems to encircle the trachea and the esophagus. This can be seen better on more caudal scans. Here what we can also actually appreciate is the lumen of the trachea being narrowed. On measurement, this lumen turned out to be 3.7 millimeters, which is a narrowed trachea. As for this particular age group, a normal trachea would vary somewhere between 6 to 8 mm. And this, after the vascular ring, there is no further luminal narrowing of the trachea. Going back to the case, what we can also appreciate here are some 3D volume rendered models made post-processing in the department, where what we appreciate is the trachea bifurcating at the level of carina into the right main bronchus, the left main bronchus. We can also appreciate an abrupt cutoff at this level in the right bronchus intermedius. There is reduced right lung volume as visualized here. On the right of your screen is another soft tissue 3D volume rendered model where we can see the tracheal luminal narrowing at this particular level corresponding to the vascular ring. There's a small indentation in the left main bronchus which also corresponds to the nasogastric tube passing posteriorly. What we see here is a 3D volume rendered model constructed post-processing in the department of the heart from a right anterior view which shows us the heart, the ascending aorta and its bifurcation into a right aortic arch and a left aortic arch. Here what we also notice is that the right aortic arch is comparatively larger and dominant in size as compared to the left aortic arch. And we can see the endotracheal tube and the nasogastric tube passing through this ring, which proves that this was indeed encircling the trachea and the esophagus. This same model is now seen from a posterior and left aspect, where we see this Y-shaped structure, both the arches meeting and forming the descending thoracic aorta. This is a subtraction model made to visualize the vascular ring, the complete vascular ring, along with the descending aorta. And this is a cine mode 3D volume rendered model. We are at an anterior aspect right now, looking at the ascending aorta, the vascular ring in its entirety, and then this arch at the posterior aspect and the left side, continuing to form the descending thoracic aorta. So the diagnosis that was given on the CT was a foreign body in right bronchus intermedius, leading to the collapse of right lower lobe, along with a double aortic arch or a complete vascular ring, causing compression over the trachea. Now I'd like to call back Dr. Tushita ma'am to take the management of the case further. Thank you.
Thank you, Dr. Ashna. Now let's review the timeline for this patient since the inception of complaints. So on 11th of February, there was the notorious history of consumption of chana, following which he developed complaints of cough and respiratory distress. On 14th of February, he was brought to Mahatma Gandhi Hospital in gasping state, intubated and started on intermittent positive pressure ventilation and shifted to PICU. Blood gases were suggestive of severe respiratory acidosis and a chest radiograph suggestive of right lower lobe collapse. On 15th of February, the CECT revealed an impacted foreign body in the bronchus intermedius on the right side and a double aortic arch. So now for the foreign body removal, a rigid bronchoscopy was done on 16th of February 2024. However, between the 16th of Feb to 20th of Feb, the respiratory distress did not decrease in spite of the removal of the foreign body, and hence the patient was referred to a pediatric cardiac surgeon for double aortic arch repair, assuming that that was causing no improvement. I would now like to invite our senior consultant, Dr. Sanjay Khatri, to review the echocardiogram of this patient in detail.
Did the right collapse, right posterior lobe, did it re-expand and the perfusion was restored after the foreign body removal?
No,
I mean,
sir.
you might have taken out the foreign body, but if the lung collapse persists, the symptoms will persist. And why going for cardiac surgery for a collapsed lung?
Right. So after the removal of the foreign body, the collapse actually persisted for about 2 days, and a repeat rigid bronchoscopy was done. At the time, it revealed thick secretions, and that was sent for a bronchoalveolar lavage, and that was pretty much normal. So given that there was accumulation of these thick secretions, suggested that the obstruction maybe at the tracheal level was persisting, and that's why a double aortic arch repair was planned for this patient.
Bronchoscopy was done in MGH.
For personal reasons, this child was taken to another hospital, so they had known people at another hospital, so they wanted to take the child there. It was not done here.
In Jaipur only?
In Jaipur.
We have a strong clinical suspicion of a foreign body aspiration.
Yes.
What is the first investigation?
So, chest radiograph, but then
Should it not be bronchoscopy?
it should be, sir, because most of the, or at least the organic foreign bodies, are actually 90% of them are radiolucent. There's only a small chunk of
So
them.
why did we go for CT in this case?
Given the radiolucency of chana and the right lobe.
So did we suspect a vascular problem on the chest
Yes,
X-ray?
sir.
So this is a very good case to illuminate so many things into consideration. So the first thing is that why child presented 18 months of age, vascular ring is there since birth. That's the beauty of vascular ring. When both vessels are patent, right and left, both arch are patent, child manifests between 3 months of age. In this case, CT people demonstrate very well. We need to admire the CT department to delineate these pictures very well. To pick this case, when you are suspecting clinical diagnosis, everything in favor of chana. We are not refer the patient to the CT department. This is the first case. Previously, we suspect that we are suspecting some vascular compression. Breathing is stridor. Stridor is expiratory. We want to see the compression of trachea and esophagus. What is the pathology? Any ring is there? But here, patient shifted to CT with the diagnosis of chana consumption. So it's beautiful that they make the diagnosis of double aortic arch. Now why patient is manifest at 18 months of age? If both arches are patent, then symptoms become 3 months of age. In this case, one arch is dominant, another is hypoplastic. So it takes some time, few weeks to few months to get symptoms. Literature says most of the patient of double aortic arch manifest from 3 months to 8 years of age, whatever the event is there. But here, chana become the hero. Because patient consumption chana, that make all respiratory tract inflamed, which manifest symptoms more pronounced. They take out the chana, but still symptoms are there. Now the whole tract is inflamed. Diagnosis is in our hand. Patient is oxygen dependent. Now only answer, need treatment of double aortic arch, and luckily we have got Dr. Kaushal here to operate this case. So my role is just to see the echo. Echo, because 10% cases of double aortic arch, maybe some congenital anomaly may be there, maybe it's VSD or maybe sometimes tetralogy of Fallot. With clinical history, don't say this, but when child is going to OT, yes, we will do the echo. Echo show double aortic arch, in which right-sided arch is more prominent with no coarctation. A small left-sided arch. It shows everything because one arch is small, one is large. So symptoms may occur later age. In this case, same thing is there. No other cardiac anomaly is there. So patient can taken for the surgery. So taken for the surgery on 24th February. Dr. Kaushal did the surgery. Dr. Tushita.
Let me ask a hypothetical question. Suppose this event had not happened, the Chana, and for whatever reason some CT was done or chest X-ray was done and there was a suspicion of a double aortic arch, would the child have required a surgery?
Yes. So what happened with the age? Compression is there. With the age, child grow. That trachea lumen 3.5 is not sufficient for the child. The child may come because child having respiratory infection that may start at 2 year, 3 year, slight noisy breathing is there which is not changed with the position. So the child may come to us with 3 year, 4 year, 5 year of age with recurrent stridor. Some noisy breathing is there. Then we did the echo and find right aortic arch. When we in the echo we find right aortic arch, we also look for the left aortic arch. If we see the left aortic arch which is not patent, it is hypoplastic, so we suspect. I am again telling, we suspect. On echo we only suspect because we can't see the trachea and esophagus compression. We suspect. Then we refer the patient to the CT people. Now you make the diagnosis. This is the first time in my 18 year I am CT people send me the case. This is double aortic arch. Now you do the echo. Previously I do the echo then send the patient to them. Now you tell me the diagnosis is there or not. So when child comes with repeated infection, 2 months, 3 months, 3 year, 4 year, 5 year, then ultimately sometime we do the echo and pick this thing. That child definitely, because Chana, such inflammation of Chana leads to compression of trachea. It may manifest another 1 year or 2 year. It may come, but luckily consumption Chana and
maybe Dr. Kaushal can take that. That if suppose it is a asymptomatic double aortic arch detected incidentally on imaging, does it require intervention or it requires intervention only when it with causing mechanical compression of the trachea to the extent that the lumen is 3 millimeter?
Okay. The symptoms, you told us symptoms. One symptom is there, noisy breathing. How troublesome this noisy breathing is for the parents, if they are worried about this noisy breathing, if they are worried, because sometimes we get noisy breathing during the adenoids and tonsil also, but not suddenly they go for the surgery. If that noisy breathing is causing so much trouble, in our experience, we not a single asymptomatic child we operate for double aortic arch. First case Dr. Kaushal operated is 3-month-old girl, admitted in ICU with such a stridor you can hear the stridor from the ear. कितना ज़्यादा स्टार्टर था उसको, compression दोनों आर्च पेटेंट थी, तभी वो 3 month में मैनिफेस्ट किया. सिम्टम्स के बिना सर हमने कोई ऑपरेट किया.
Reason behind was just a trigger. So this baby would have anyway would have required surgery. If not now, probably 6 months or 1 year.
Sir, I have a question regarding the double aortic arch and this acute event of foreign body impaction. Sir, it would have been better that first we would have treated this acute event, discharged the child, because there was no previous history of admissions in this child for past 18 months. This was the first event when he got admitted with respiratory complaints. So would have been better that we should have discharged this child for this event and then again call him back for the further surgery.
I am happy Dr. Roop you asked this question. They remove the foreign body from the outside hospital, but they are not able to wean off the child from oxygen. Child is persistently distressed and saturation is not crossing more than 92. So what's the option? We have double aortic arch, inflamed trachea, compression is there. Whether we can wait for another 3 months, antibiotic coverage is there, CRP is normal, child is non-infection, family is ready. Why to not operate this one?
So basically he was operated on the same ventilator settings initially and then again he was extubated after that.
I think another point which I would just like to make is when a child comes to you with a certain history of, a short history of certain dyspnea, first thing which needs to strike your mind is the foreign body. No confusion. In such a situation, a history also has to be taken just for the sake of evidence, whether a sibling had been there to put the chana over there, because normally parents are quite careful about these. Second thing is the child is having a noisy breathing since 1 month of age. Now that again is asymptomatic, otherwise no other symptom. So a tracheomalacia or laryngomalacia should be a possibility which is to be considered over there with noisy breathing without any symptoms of indicating for a cardiac issue.
But that is ruled out by pediatrician. In both the situation, if baby is in supine, get a noisy breathing, prone breathing is disappear. But here no relation with the change in the position. But it's not much troubling to the parents that they come for this problem to the hospital.
So my submission over here is that is a classical presentation in a laryngomalacia or tracheomalacia. However, positional changing of the stridor may not happen. So the child may be dyspneic or maybe not dyspneic, maybe a status in a stridor in the normal situation also in any position. So that's something that just has to be kept in mind over here. And but one thing is definite, that whenever a short history of dyspnea is there, you must suspect a foreign body, and normally you are not wrong over there.
That's why I admire the radiology department. They took the patient for foreign body. They can come out easily, right bronchus obliterated, but they see the case as a whole. A diagnosis of double aortic arch really is a
Moreover, it was a biphasic stridor.
Yeah.
So if it is tracheomalacia of a very long segment, then it may be like that.
Yeah.
Otherwise, in a tracheomalacia, intrathoracic, you will have one kind of a stridor, and if it is extrathoracic, it will be extrathoracic. It will be inspiratory. Intrathoracic will be expiratory.
Sir,
and here it was biphasic, so it is.
But I presume biphasic because whole laryngotracheal malacia tree is inflamed.
It is
said by stridor is biphasic. Otherwise, tracheomalacia give expiratory stridor.
And this entire segment is intrathoracic.
Yes.
Thank you, Dr. Khatri, sir. Now we will be looking into the surgical correction, the double aortic arch repair that was done for this patient. So first let's understand a little bit of normal anatomy. So this is the normal aortic arch. It starts at the level of the second sternocostal joint and extends up to the lower border of the fourth thoracic vertebra. It gives off the right innominate artery, the left common carotid and the left subclavian artery. And normally, arch-sidedness is defined by the position of the aortic arch in relation to the trachea. So in majority of the population, it's a left-sided aortic arch. That is to say that the arch of the aorta is to the left of the trachea and arches over the left main stem bronchus. Now what happens in a double aortic arch is that the ascending aorta, it splits into an anterior left aortic arch and a posterior right aortic arch. And both of these arches are going to merge together posteriorly on the left side to form the descending aorta. And in doing so, they form a vascular ring. So this vascular ring encircles and compresses the trachea and esophagus, causing varying severities of respiratory and gastrointestinal symptoms depending upon the degree of compression. So in 75% of patients with double aortic arch, the right arch is the dominant one, that is to say it is larger in size, and the left arch is the smaller one, it may be atretic. So this is a CT image that has already been elaborated in detail. Let's look at the intraoperative image of a double aortic arch. Again, this is the ascending aorta splitting into the right aortic arch, which is going posteriorly, and the left aortic arch, which is going anteriorly. So again, 75% dominant right aortic arch, in 20% dominant left aortic arch, and in the remaining 5% it may be a balanced type of arch where the difference in the size between the two arches is less than 5%, so they are more or less equal. So coming to the surgical technique, there are two approaches to the surgical site. One is through a lateral thoracotomy and the other one is through a medial sternotomy. For our patient, a medial sternotomy was done. In either case, it's important to identify both the dominant as well as the non-dominant arch. Especially if you're doing a lateral thoracotomy, the side of the lateral thoracotomy will depend upon the non-dominant arch, since that is the one which is going to be divided and ligated. So once we're at the site, we will divide the smaller arch and we'll also divide the ligamentum arteriosum, which is a remnant of the ductus arteriosus between the pulmonary artery and the arch. So this is a schematic representation of the surgical technique. In image A, we can see the dominant right aortic arch and the dominant smaller sized left aortic arch. In image B, we can see division of the smaller non-dominant left aortic arch. and also the ligamentum arteriosum. Here we can see the fascia around the trachea and esophagus has been divided to release the vascular ring. And then in image D, this is the distal end of the divided non-dominant left aortic arch, which is then reflected and secured to the intercostal tissue. So these are the intraoperative images and videos from our patient. This is post-division of the smaller non-dominant left aortic arch. Here we can see the proximal end of the left aortic arch, and this is the right ventricle, the pulmonary artery arising from there. And what has been annotated as the aorta is the dominant right aortic arch in this patient. So this is an intraoperative video. The arrow is basically pointing to the direction of the divided non-dominant arch. Again, these are intraoperative images from our patient. We can see the proximal as well as the distal end of the divided arch. And again, in the intraoperative video, we can see the proximal end, the distal end, and here retracted is the dominant right aortic arch. And here would be the ligamentum arteriosum that has also been divided. Now I would like to call upon Dr. Sanjay Khatri sir once again to discuss the post-operative echo.
You used to smaller arch and non-dominant. So is it the diameter which is important or
Yes.
is the flow?
So the diameter, the size of the arch.
So we did the post-op echo after the surgery to see the it shows well open right aortic arch, smaller left aortic arch is ligated, PDA is divided, so no problem in the arch. Normal flow is seen. This patient came to Mahatma Gandhi hospital 7 days back. Child was doing well. We did the echo, function normal, no AV1, no regurgitation is there. Everything is normal, no pericardial effusion. Child is free from any respiratory or cardiac symptom. Advice to review after birth.
So for the patient, I have a question. For the patient to have a right-sided arch for the rest of his or her life, is there a problem there or there is no problem at all?
8 to 10% normal have a right aortic arch associated with more incidence of Down syndrome and intracardiac anomaly. But normal person can also have right aortic arch. Maybe I have right aortic arch.
And any anticoagulant stated for the diet? Nothing. So normal life. No restriction of physical activity. You have to do a careful search for other vascular abnormalities and other congenital abnormalities.
CT very well, no other abnormality is there. Vascular, if there, person shall have detected that time only.
So there is one disclaimer to be made. Dr. Sanjay Khatri's wife is a radiologist.
No, sir, that's not the reason I am admiring. This work in radiology is very good and that's why I admire it.
So I would like to second that. Our radiology department is doing a really good job. We have lots of clinical trials going and the major amount of extra effort in reporting clinical trial X-rays and CTs, they are doing without any complaints. So very thankful for that.
Excellent recreation.
Let us congratulate the Department of Radio Diagnosis for presenting excellent 3D reconstructions. They look so real and so informative. We would like to know how do we do it. And one more thing, when we presented it, it would have been great if there was a small review of other vascular rings and slings also. You know, that gives a clue. Yeah.
Thank you, Dr. Khatri sir. I would now like to invite Dr. Pratul Kaur ma'am from the Department of Anatomy to continue.
everyone. Thank you, Dr. Tushita. Now, I will discuss the development of the aortic arch. In the 4th to 5th week of development, there are 6 pairs of arterial arches which appear in the pharyngeal region. These arterial arches connect the developing heart tube in the front with the two dorsal aorta behind. Now, the upper or the superior 3 arterial pairs of arterial arches, they are concerned with the development of the arteries in the head and neck region. The maxillary artery, stapedial artery, and the internal carotid and common carotid arteries are derived from them. The 4th arch or the 4th arterial arch is concerned with the development of aorta. Now, only the left 4th arterial arch is involved in the development of aorta, and right 4th arterial arch per se it regresses and it contributes in the development of the right subclavian artery. The 6th arterial arch is also known as the pulmonary arch, and it forms the 2 pulmonary arteries. Now, when in the 7th week the right arch, most of it regresses, and the 4th arterial arch, it forms the arch of aorta with contribution from 2 more components. One is the truncus arteriosus and the second is the dorsal aorta. So now complete aortic arch is formed by 8th week or 7th to 8th week of development, and on the right side only the right subclavian artery persists. Now, if this right arterial arch, it also persists, then a double aortic arch will be formed. This right arterial arch will pass behind the developing tracheoesophageal bud, and a complete vascular ring will be formed around the trachea and esophagus. As discussed earlier, now there are 2 channels through which the blood will flow. One channel might be dominant, so blood flow in that channel might be higher, so there might be a right dominant arch, a left dominant arch, or a co-dominant arch. In our case, it was right dominant arch, and so that's why left arch, which was smaller, that was resected. So this is about the development of the double aortic arch. Now I would invite Dr. Ashna from the Department of Radiodiagnostics.
One question, Dr. Bajwa, can you tell us whether some of the vessels can be arising from non-dominant arch, and if such thing happens, then Dr. Kaushal will tell us what do you do.
So there are other arch anomalies too, like there can be a right persistent arch, and left subclavian artery might arise from the other side. Similarly, there can be a left persistent arch along with the aberrant right subclavian artery arising from the other side.
Absolutely right, sir. I have seen few cases representing like pulmonary sling. So those such arches, persistent arches are 50% sling. So we have to divide that sling as well. Not with the vascular relief is such a sling.
Thank you, ma'am. Although we have established the rarity of our case, we'll still go through the review of literature in very brief with what statistics we have available in the reported literature. So, double aortic arch is a rare congenital cardiovascular malformation constituting of about 1% of overall cardiovascular malformations. Globally, the prevalence stands at 0.005% to 0.007%. Which is an underestimation, as a lot of these cases can be asymptomatic or undetected. There is no gender predilection as such, and in Rajasthan we've operated about 8 to 10 cases out of the total 5,000 operated cases of congenital heart diseases in the last 12 years, and we have the fortune of having Dr. Sunil Kaushal sir here with us who has operated these cases. Thank you so much, sir. The first description of this double aortic arch was in 1737, which was actually in a post-mortem study. And here are a few examples of case reports of the same. We are also in the pipeline of publishing this case as a case report.
Sir, shall we continue? Like we have two short cases presented by Dr. Arzoo. Shall we continue or please?
So there, hardly 5 minutes. Okay, so I'll call Dr. Arzoo to take the case spectrum forward. Thank you.
Good morning, everyone. Now I'll briefly describe about the imaging spectrum of other two interesting cases that we have recently diagnosed in our department and are lined up for surgery in next few weeks. So this is a CT scanogram. Can any one of you detect any abnormality in this? Okay. So here we can appreciate vascular markings are prominent in bilateral upper zones, hilar region and perihilar region. There is also evidence of prominence of cardiac cell house. There is right atrial enlargement, right ventricular enlargement with apex of heart pulled upward. Now we have the CT pulmonary angiographic images of the scene. Normally, all the four pulmonary veins drain into the left atrium, and there is no such vein in the lung parenchyma that directly drains into the superior vena cava. But in our case, there are multiple superior pulmonary veins are seen to be arising from the apical segment, anterior segment and the posterior segment of the right upper lobe, and that is draining into the superior vena cava. So these are the axial section maximum intensity projection images. We can appreciate apical segment pulmonary vein draining into superior vena cava, posterior segment pulmonary vein draining into the superior vena cava. The main pulmonary artery and the right pulmonary artery is markedly dilated, and the caliber of ascending aorta and descending aorta is reduced. Again, these are the axial section. Here we can appreciate anterior segment pulmonary vein draining into superior vena cava, right middle lobe pulmonary vein draining into the superior vena cava. These are the coronal section, and here we can see bilateral inferior pulmonary vein and left superior pulmonary vein. These veins are draining into the coronary sinus and further drains into the right atrium. This is the axial section showing right atrium and right ventricle are markedly dilated, whereas the caliber of left atrium and left ventricle is reduced. There is also evidence of atrial septal defect. IVC is slightly prominent and there is mild pericardial effusion. So quickly summing up the above described finding, our radiological diagnosis, this is mixed type of total anomalous pulmonary venous return. This is the next case, this is the CT scanogram. And here we could not appreciate the normal aortic knuckle as we can appreciate in this the normal chest X-ray. We can also see bilateral inferior rib notching, and these things are the possible diagnosis is coarctation of aorta. We did the CT aortogram of the same patient. These are the sagittal images, this is the venous phase, this is the arterial phase. Here we can see focal concentric narrowing of the aorta distal to the origin of left subclavian artery with post-aortic dilatation. We can also appreciate multiple paraspinal, intercostal and posterior chest wall collaterals. These are the volume rendered image showing the same, that is the focal concentric narrowing, and this is the coronal maximum intensity projection image showing enlargement of bilateral internal mammary arteries with extensive collateral formation in anterior chest wall and abdominal wall. Summing up the above described findings, the radiological diagnosis is post-ductal coarctation of aorta with extensive collateral formation. Now, I would request Dr. Paresh Kumar Sukhani, Professor and Head Department of Radiodiagnosis, to please conclude the presentation.